The documentation guidelines establish that a chief complaint needs to be documented at each of the 4 different recognized levels of history. Now, in an audit scenario, if there was a visit note that had a relatively robust history, however, there's no documented chief complaint, there's a possibility that an auditor could say no credit is allowed for history because the chief complaint is documented. Because of that, it's really a good habit to get into to document the chief complaint for every single patient visit. This is typically not problematic for any office-based services. It's typically not problematic for admissions in the hospital or consults in the hospital. Where I see this being problematic quite frequently is with hospital progress notes. So it might be day 3 or day 4 after admission for an acute problem. The patient's stabilized. The cardiologist is rounding on the patient and essentially, either preparing to sign off on the patient's care or actually signing off on the patient's care. Even in that progress note, it's really important and beneficial to document what the chief complaint is. There's no requirement that you use the words chief complaint or label it as chief complaint. Simply stating something like follow-up to coronary disease or follow-up to MI. The patient is asymptomatic today and okay to discharge tomorrow as long as the hospital signs off on it. Whatever you put in there, just make sure to establish why the patient is being seen today, because this chief complaint essentially establishes the medical necessity for the visit. If the beginning of the note just says this patient's fine, they have no symptoms, no problems, it leaves the door open for an auditor to come back and say, well, what's the medical necessity for this patient to see a cardiologist today? So, little housekeeping point, but make sure to document a chief complaint. The history of present illness is by far the most common limiting factor in cardiology notes, and this is one that really should not be a limiting factor because it's extremely easy to meet or exceed the requirements. However, there's a couple of assumptions that I see physicians making that are just false assumptions, which cause notes to be a lot more verbose than they need to be and still falling deficient in regards to this component of documentation. So real briefly, the history of present illness consists of 8 different recognized buzzwords, and these are kind of illustrated kind of down here. You can see that the 8 buzzwords that they recognize are the location, severity, duration, timing, context, quality, symptoms, and modifying factors. These are each pretty self-explanatory, so I won't go into great detail about each of those. The 2 things that I find physicians making false assumptions on is first that they assume a lot of times that if I just put a whole bunch of words in there, that it'll support the level of service that I'm trying to bill for. And that's really not the case. You can have a well-crafted 1-sentence HPI that hits on all 4 of the HPI components as opposed to a 3-paragraph HPI which only hits on 1 or 2 of the key components. When you're billing for your higher levels of service, which are going to be your most common levels of service in cardiology, you need to hit on 4 of the recognized HPI elements. So this specifically applies to that 99214, which is truly your most common service in cardiology. It also applies to the 99215, your 2 highest levels of initial inpatient care, your 2 highest levels of established patient office visits. For a lot of services that you're billing for, you're going to need to hit on 4 of these recognized HPI variables. When you get credit for one of the HPI variables, you cannot get credit for that variable a second time or a third time. So if we're shooting for this variable of symptoms, once you document that the patient has been complaining of chest pain, you'll get credit for associated signs or symptoms. If you then go on and list out 5 or 6 other symptoms that the patient either has or doesn't have, you're not going to get any additional credit in regards to the history of present illness. So what you need to do is after you get credit for symptoms, kind of consider that one off the table. Like you're playing a game of Tin Can Alley, you shot that can off the ledge, you can't get credit for shooting that same can off the ledge again. You need to take aim at one of the other HPI variables and knock that one off the ledge. And essentially you've got to hit 4 different recognized HPI variables in order to support a 99214 or any of these other high frequency services. The second false assumption that I see some people making is that the patient has to give you positive responses to your questions about the HPI in order to get credit for. So I see a lot of physicians that'll ask, how do I get 4 HPIs if the patient's asymptomatic? It's very easy because you get credit for these questions whether you get that positive or a negative response. So if you were to say that the patient denies any symptoms, you're still going to get credit for that 1 HPI variable. And then assuming that you know the physical location of the patient's problem, even if that's just as generic as coronary artery disease, that still gives you the location of the patient's problem. The severity of it, you could document it as simply as mild, moderate, or severe. With heart failure, you could say what heart classification, New York Heart Association classification of heart failure the patient has. If the patient has hypertension, documenting how hypertensive they are counts. The duration of the problem could either be how long they've had the condition that you're seeing them for, or if they're symptomatic, how long those symptoms persist. With timing, you could say the patient either denies that their symptoms are worse or better at any specific time of day. That would be a negative response, or a positive response would be the patient's symptoms are more pronounced in the evening just before bedtime. Modifying factors is another one that's very easy to document as positive or negative. And it makes it so that one-word sentence could be something as simple as saying that the patient has mild coronary disease. She denies symptoms even with physical exertion. And I basically told you the location of the problem, how severe it is, the fact that the patient does not have symptoms, and the fact that there are no modifying factors. When we're documenting the HPI, a couple of really important points to make is first off is that the HPI needs to be obtained and documented by whoever is billing for the service. So this is the only component of history that needs to be personally obtained and documented by the physician. The HPI needs to be obtained and documented fresh at every single visit, even in the hospital setting. So the HPI, by definition, is what's happened with the patient since the last time we saw them, or if it's a new patient, what's happened with the patient since the initial onset of the problems that we're seeing them for. So by definition, we can't carry forward an HPI as opposed to the other elements of history, which I'll show you in just a bit, which do allow you to carry forward if you document certain variables in your note. So let's take a pause here and go to a couple of questions just to make sure that you understand this part. As I mentioned, this is the most common limiting variable in cardiology notes, so it's extremely important to fully understand that you got to hit 4 HPI variables to support your most common services. You get credit for positives and negatives, and you can only get credit for any one of the 8 HPI variables one time. So saying that the patient denies chest pain gives you credit for symptoms. Saying the patient denies chest pain, shortness of breath, paroxysmal nocturnal dyspnea, nausea, vomiting, and